Hello, and welcome to this COVID-19 coffee chat on using telehealth services for patient care. I'm Lily Catalano, Project Manager for the National Healthcare for the Homeless Council in Nashville, where it's a very rainy day, perfect for a coffee chat. This webinar is supported by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services, as part of an award totaling $1,625,741 with 0% financed from non-governmental sources. The contents are those of the authors and do not necessarily represent the official views of, nor an endorsement by HRSA, HHS, or the U.S. government. For more information, please visit hrsa.gov. In response to the COVID-19 outbreak, many providers serving people experiencing homelessness have quickly shifted to offering a number of services via telehealth. In this time of rapid adaptation, they've implemented new technologies and processes in a matter of days and weeks. During today's chat, we'll hear from several providers about how this shift is going, what opportunities do they see, what challenges have emerged, and what ideas they'd like to share. Undoubtedly, many of you have also rapidly pivoted to new ways of delivering services during this pandemic. We would love to hear your stories and ideas as well. Our format for today's hour is a coffee chat, and we call them coffee chats because they're informal conversations. We invite you to get a cup of coffee or your lunch and listen and discuss. This is an opportunity for us all to share tips, challenges, and support for each other, and we hope you'll engage throughout. I see a number of folks already saying hi and introducing themselves in the chat pod, so thank you so much for getting that going. And in addition to the information and ideas we'll be sharing today, we hope that this hour might be a chance for you to take a break from the critical work that you're doing in extremely trying circumstances, and to know that you're part of a network of thousands of people doing similar work all across the country. So some instructions about how you can engage during the chat today. We welcome your questions and stories throughout. The more you all engage, the better the chat will be. You can type directly into the chat box on the right side of your screen. Your comments will show up to all participants, and I'll refer things to panelists as they come in. So first up, let's see who we've got in the room today. I'll be posting a poll question in just a moment. And you can click your response right there, but who is joining us today? You can click all that apply and share what type of organization you come from and what perspective you bring. Looks like we have many from Healthcare for the Homeless programs and other health centers or healthcare providers. Also COC, homeless services providers, a lot of folks from government or public agencies, and folks in policy, legal, research, advocacy, folks from alternate care sites and isolation and quarantine programs. So great, we have representatives from lots of different types of service providers. Great. Before I introduce today's panelists, I want to point out the resources pod on the bottom of your screen. There is a NHCHC COVID-19 resources link that will take you to a page with all kinds of COVID-19 guidance specific to homelessness, created by the National Healthcare for the Homeless Council and other partners. There's also a link to a telehealth resources page that has a lot of helpful information, including links to the Telehealth Resource Center that has published a lot of guidance that may be applicable to our conversation today. And then below those, there are links to where you can register for upcoming COVID coffee chats. The Council is having these conversations every Tuesday and Friday in the coming weeks at this same time, 1 o'clock Eastern. So you can click on any of those to register for the next ones. Tuesdays is on continuity of care for residents and permanent supportive housing. And now I'm very happy to introduce today's panelists to you. They are Jan Ferdous, Joanna Denhan, Marty Mary McNally, Regina Olasin, and Marty Sabol. So welcome. I'm going to invite each of you to tell us a little bit about yourselves and your organizations.
Hi, this is Jannatul. I am the Director of Behavioral Health at Healthcare for the Homeless, downtown Baltimore, Maryland. We actually provide, we are multidisciplinary. We provide medical, mental health, addiction, pediatric, dental. Am I missing something? Mostly these are the big services that we provide. But I oversee the behavioral health, which is part of both mental health and addiction. In 2015, we merged addiction and mental health together, and we are a big behavioral health department now. We provide individuals, we provide groups. We also have very structured substance abuse program, IOP, OP, and also mass medication assistance treatment program. And I'm happy to be here today. Thank you for inviting me.
Hi, I'm Joanna Denhan from Seattle, Washington. I work for Neighbor Care Health as our Homeless and Housing Programs Manager. We are a federally qualified health center in Seattle, Washington, serving over 75,000 patients a year. And we provide dental, medical, and behavioral health care as well. I oversee our homeless clinics and programs, and so we have a homeless clinic for adults, a homeless clinic for youth and young adults, as well as a lot of work, outreach work in 16 permanent supportive housing buildings in Seattle, as well as on the street. We're doing a lot right now with mobile COVID testing, medication-assisted treatment, and the best we can with telemedicine. Glad to be here.
Can you hear me?
Yes.
Yeah.
Okay, thanks. Sorry. Okay, I just wanted to double check. I couldn't remember what I unmuted. This is Marty McNally, and I'm the Director of Behavioral Health at Nasson Healthcare, which is in Springvale, Maine. And I will let my boss, who's also on this panel, tell you more specifically. But the behavioral health program has been around for about 14, 15 years, and we started out as purely a healthcare for the homeless program, and worked in close conjunction with a shelter in our area, as well as some housing projects and other situations. Eventually, at this point, we have more of a general behavioral health program, a HRSA. We have, let's see, I have 4 clinicians. We're a pretty small rural healthcare center, and we see people for everything from help with getting out there and walking because you have, your diabetes, your A1C is out of control, to people who are schizophrenic and everything in between. So it's wide variation. In Maine, we've had a struggle trying to get mental health services for people who don't have resources, who don't have health care. So that was kind of, in some ways, how we ended up doing more mental health, along with what is sort of more classically behavioral health. And also, I'm glad to be here.
Good afternoon. I'm Regina Olasin. I'm the Chief Medical Officer at Care for the Homeless in New York City. We have a primary care network of 19 federally qualified health centers in Bronx, Brooklyn, Queens, and Manhattan. And
We have behavioral health integrated with primary care, and 2 of our sites provide consultative podiatry and dental. We've had a sort of germinal telemedicine program up until the past 2 months, when it's really, I guess, I don't want to say exploded, but it's expanded significantly. New York has had the opportunity to dramatically change how care is delivered, and will probably continue to have to raise and change bars and expectations as we move forward through this pandemic period.
So hello, Marty Sabol here. Here at Nasson, Marty McNally is Ms. Marty, and I'm Mr. Marty. You can call us.
Sorry about that.
So yeah, Nasson Healthcare has, as Marty said, has its roots as a healthcare for the homeless and public housing primary care health center, and with Affordable Care Act funds in 2012, we were able to broaden our focus to serve our entire community. York County is the size of the state of Rhode Island geographically, but has only just under 200,000 residents. Our service area is largely rural. People who are experiencing homelessness tend to be more doubling up, living in sort of unstable housing, but we don't have much for homeless shelters. We have one very small organization, larger shelters in neighboring Portsmouth, New Hampshire, and Portland, Maine. We attempt to integrate medical, behavioral health, care management, dental services as much as we possibly can. Since the start of the COVID-19 pandemic, we have had to contract significantly. We've closed 2 of our sites. We're now operating just under 1 roof. Many of our, about half of our staff is either working from home or just not working at this point. And I'm glad to be here too.
Well, thank you all for being here today. So I am going to start us with some discussion questions. I will ask those to the panelists and also invite any of the attendees to respond as well in the chat box. And again, feel free to raise any additional questions that you might have throughout. So I'm curious about how your organization is using telehealth to provide services and how that's changed since the COVID-19 outbreak. Some of you sort of alluded to the dramatic shift that's happened, but let's hear about the specific services and how much that has evolved over the last few weeks. Joanna, would you like to start us off?
Sure, thank you. Yes, here in Seattle, Neighbor Care was not doing a lot with telehealth previously. We really just realized a need to pivot as soon as we were not able to safely bring as many people in for services into the clinic. And so we've done it a couple of different ways. Right now we're providing telehealth for both behavioral health and medical care. And we're doing that. So we're both a 330E qualified health center, and we have 330H dollars subcontracted. And so we're doing both for our homeless and general populations. And I'm trying to think. So yeah, it feels like it's changed dramatically. We're pretty much just using audio-only telehealth right now, and still thinking about exploring video, but it felt like a more nimble, quick way to get things off the ground.
Thanks. Regina, how about Care for the Homeless?
So we've done a number of different options. Our electronic health platform is eClinicalWorks, and they do have a telemedicine option for individuals who are web-enabled and are on the portal called Helo, and that actually can be downloaded in the event someone has a smartphone. Majority of our patients do have phones, not smartphones. Most of them are the phones that they got when they enrolled with the Affordable Care Act, and those are like able to receive text but not really able to do very much more. So we've launched a combined program for behavioral health services, all virtual, telephone, and where possible, audio-visual visits through web-enabled functionality. And then for primary care, our practitioners are on site, and our population health has contacted everyone who had a pre-booked follow-up appointment and recommended, with the patient's consent, that it be converted either to a telephone encounter or a telemedicine encounter. And in the event that individuals certainly wanted to come in for a face-to-face encounter, that option remained possible. And we separated the scheduling for face-to-face encounters dramatically, so there would not be, we have small spaces anyway, and we wanted to be very deliberate about social distancing and physiologic distancing, actually. And now we have a really interesting new challenge within the past 8 days, that all of New York City shelters are being, adult single shelters, are being transitioned from shelter environments to hotels at about 1,000 a week as individuals. So we've had the unique opportunity of having 2 complete shelters repopulated into 3 hotel locations. And we're working, as we speak on this call, with T-Mobile to try to obtain a number of health helo-loaded cell phones with geographic limitation for call functionality to be able to use as an incentive for connectivity and continuity of care. And I suspect it'll all evolve further in the next few weeks.
That's great. Jan, how about in Baltimore?
Yeah, so in Baltimore, mostly, like everybody said, like we didn't have much time to prepare for this. It was just suddenly that we shifted from one-on-one in-person visits to telehealth. So we're doing mostly audio only, and we're using our own cell phones. So behavioral health team is actually doing most of the telehealth from home. We do have a rotation schedule. We want to be 1 to 2 staff to be in the clinic, because we also still have walk-in available for those clients that don't have phone services or they prefer to come in. But yeah, we are mostly using audio only, and our medical team is actually functioning. They are seeing clients in the clinic, but still, as much as possible, we're using audio only. We're looking into different platforms, but yeah, for now, we're just using our own cell phone to reach out to our clients and have these audio telehealth services.
Thank you. How about in Maine, Marty and Marty?
Mr. Marty, why don't you go?
Yeah, okay, Ms. Marty, I'll do that. So yeah, we have no experience with telehealth either. Prior to March of this year, when the emergency hit, we made the snap decision to, we were obligated to offer only essential services in person, and we decided to offer all behavioral health services by telephone, including psychiatry and other behavioral health services. Probably 80% of our medical appointments were converted to telephone if that was appropriate, and for acute medical problems, we continue to see people face-to-face, but after screening by telephone, and then again as people arrive, folks are queried for symptoms, and then their temperatures are checked. So if folks get through the screening and they have acute needs, then we see them in person. And for dental, we're only able to do dental emergencies for people who are screening negative. Our hope is to, based on our experience with this, though, we were very interested in picking up a video component to the telehealth service, actually developing the body of policy and certifying our system to go forward with full telehealth in the future. Behavioral health, Marty will talk more about that, but it's been very successful in terms of patient and provider experience. Providers and patients can work from home. They each are able to work from home with basic telephones, and we're looking at vendors to sync with our next gen system to be able to add a video component.
So, as Mr. Marty said, behavioral health is 100% over the phone right now, and I think that's probably going to be changing a little bit in that we now have enough sort of time under our belt doing this. It's been, I don't know, a month, I think. We need to go back and be sure that we haven't inadvertently left anyone out who would prefer to come in and figure that out, or come in or do a video kind of session. And we're not quite set up for that, but it's right on the horizon. I have heard from, it's very interesting, and I suppose we'll talk more about this, but patients, like most people, I think, that I'm seeing at the chat here, the no-show rate has gone down. It's really interesting, but I guess not that people's lives are chaotic and their transportation, especially in a rural area, extremely difficult. So that, I guess it's not that surprising. I thought at first people are a little clumsy on the phone doing a session, but as time has gone on, it's really pretty darn smooth. I think people enjoy it.
Thank you. And my next question was what's working well? And you've all sort of gotten into several of these points. But what, Jan, what would you share has either surprised you or maybe wasn't a surprise, but has been a positive aspect of this change?
I think one thing that I'm actually liking about telehealth is that it's flexibility. I think we're able to get to our clients because of this we serve mostly homeless population, and we have seen it has been a challenge for them to keep scheduled appointments. And having this telehealth, like it happened to me several times, and I'm sure my colleague will agree to it too, that we call and sometimes my client is not available, or he or she is out in the community and will tell me, okay, I'll go home in half an hour, can you call me back? And that gives me an opportunity to call my client back. So in that way, I think we're having more accessibility to reaching out to our clients, and that's actually a very positive surprise that I'm noticing that. And our no-show rate has gone down, actually. We got an access stat for the last couple of weeks, and which shows that the numbers have actually gone down. And our utilization number has also gone slightly up, I think because of this flexibility that we are able to reach our clients when they're available for us. And
thank you. And thank you.
Sorry.
Go ahead.
I just wanted to add that, in Baltimore, public transportation is a big problem, and a lot of our clients have a lot of worry and anxiety about taking public transportation. They have cut down on buses. So this is also actually very positive thing that our clients don't leave where they leave, and then we can have this session that takes care of a little bit of their anxiety among other anxiety that they're having now. Thank you.
Sure. And several folks have mentioned in the comments that they're seeing no-show rates go down, and that telehealth is increasing access in that way. So that's definitely a positive that people are seeing. Regina, what about positives that you're seeing?
I would probably echo the same things that have been mentioned. Interestingly, we had a real plummet in visits at the end of March and the beginning of April. We went down to below 30% of what we had been seeing, and that was at the point when we really re-engineered everything and started doing this program. and we're back up to 72% of our usual monthly primary care and behavioral health rate of visits, which was really not expected for any of us. The access, I think that the big challenge is going to be, as this passes and we move forward, it's going to become a new expectation from patients, and that that we're going to all need to probably think about how we make this part of what everybody's daily schedule is, and it'll be interesting to see if the reimbursement schemes kind of follow what they've been in an emergency situation. All of last year, we did 85 consultative psychiatry telemedicine visits, and the month of April, we did 1,021 televisits. That's kind of, I think that's a big transformation,
Wow, no kidding. Joanna, do you want to add anything about positives you've seen in Seattle?
Sure, happy to. I think one thing that was somewhat surprising to us was how much some folks really like it, especially for behavioral health, in terms of just, I think some people really miss the face-to-face. Some people have really liked having more distance, I think, and being a little bit less worried about sort of their appearance, or I don't even know how to say that, but it's taken off some pressure is what they've been sharing with our behavioral health. So I think that's an interesting, definitely not everyone. I think another success from the medical side has been for our youth and young adult clinic. We operate in a couple evenings a week, and we have minor shelters for youth in the area that typically transport a number of their folks in a van, which obviously is not a safe or socially distant thing to do. So it's really helped us keep services up there. And because of the connection to the shelter, really have the connection to case management to help get patients on the phone, on a shelter phone. That's been a little bit harder in permanent supportive housing, where there's not as much staffing per, I think, resident ratio. And I can talk a little bit more about PSH, I think, in the challenges section. But yeah, I think in successes, just surprised at maybe the number of people that eventually jumped on and found that they have enjoyed being able to access via phone.
Thank you. Marty, what about in Maine?
Well, as I said, I think as other people said, the no-show rate is down, and I think that over the telephone, because we don't do video chatting, but telehealth does kind of take some pressure off of some people, because most of the people that we see in behavioral health obviously have a pretty high degree of depression and a pretty high degree of anxiety. And sometimes it's a big deal for people to have to, of course, with those kinds of challenges, to get out in the world and to get to us. And not that it's probably a good challenge, but I think it's a challenge that sometimes isn't met. If somebody's having not such a great day the day of their appointment, they cancel or it's a no-show. In this sense, people can be having a really bad day or whatever, and we're still there. I think I'm trying to think of other positives. I mean, there's definitely a little bit of downside, but I think we're going to talk about that later. I've found, like I said, some people without the, I don't want to say pressure, as somebody said, but whatever, of face-to-face, that if anything, their behavioral health appointments, they're a little more vulnerable and a little more revealing. And maybe that's because they're home and they're comfortable and they're safe, and it's not an office. They didn't have to put out a whole bunch of energy that they may not have to arrange to get to the office. So anyway.
Yeah, that's so interesting. Mm-hmm. Go ahead.
Mr. Marty, do you have anything to add?
No, I'm good. I think you nailed it.
Okay.
Now, I've heard some providers talk about the sort of different skill set involved in providing services via telehealth versus an in-person visit, and the challenge of creating a personal connection and building rapport. And I wonder if you all had any strategies that you have found to be helpful in overcoming that challenge. Regina, would you like to start this time?
I think it's creating this personal connection type of thing, and also, you know, I guess there are two different parts of it. Some of the providers have felt that they don't have a connection, and then how do the patients feel? We've really had like a multi-tiered team approach to it. Having the initial transition to a virtual appointment made by a population health specialist, I think has been unique and contributed to the success, because it's not simply a transactional call to say we've changed the appointment, but it's someone whose education and focus to date has been engagement, and really explaining that, you know, we're in response to the pandemic, we're doing this, and they're saying, you know, we'd like to offer you the choice, and then that's further confirmed by the providers. Providers, interestingly, I think have not verbalized, even the behavioral health providers, feeling a lack of connectivity. We've had an amazing amount of anxiety, verbalized by everybody, but the anxiety is more about the actual effects of contracting COVID as opposed to other things. I think it's been the conversational tone, really, and offering an option that's made a difference.
Thank you. Marty, anything that you all have found to be helpful in sort of building a connection remotely?
I think it's really critical. It sounds really basic, but is to recognize, to talk to people about what is this like? What did you expect? Is it what you expected? Is it better? Is it worse? What do you miss? But not taking the time to acknowledge the difference, and that there's maybe positive things and maybe not so positive things. That seems to help. If that can be a topic. Let's see. I think it requires, and I don't know for the medical providers, but my guess is that there's something pretty close to this. Sometimes being more creative, in the sense that certain parts of a relationship with a provider certainly are visual, and like trying to figure out from people, you know, where are you, and when we're breathing, I'm not really, you know, normally maybe you'd be matching my breath, but right now I kind of hear you gasping, so let's do it much slower, or whatever it might be. But finding a different way to do what you're doing. I do EMDR, and they're really, you can do it without even a visual. You can have people tap. I haven't done it yet, but it's definitely on the horizon. I just think you have to think about things. You have to think about how else could this work. Yeah. Okay.
With our medical visits, telehealth visits, we've been playing around with 3 roles. You know, checking the patient in and out, and then we're now having medical assistants start the visit and do some of what they would normally have done in terms of rooming before the visit, and then the medical provider comes on next. One of the challenges, though, is it's sort of hard to sync things up, especially when the medical providers are interspersing telehealth visits with face-to-face visits. So the medical assistant will queue things up. Then there's this dead space for 10 minutes, and sometimes the patients will hang up, and we've got to get them back. So we're still working out a lot of the bugs, but I haven't heard from medical providers that they've had a great deal of difficulty making this transition. I mean, they're mainly working with patients they know anyway, so it's not like a new people and a new mode for service delivery. It's same people, just by telephone now.
Joanna, what have you found to be helpful?
Yeah, I was going to jump off what Marty was saying. Actually, I think in terms of being able to make the personal connection, the biggest anxiety and fear that our providers had was really around new patients, especially for behavioral health, so initiating care. And I think as they got into it for new patients, they found that it worked, and they, definitely did some case consulting and sharing best practices amongst each other. I think it's always awkward a little bit the first time, but I also think people are so desperate for the care and service, and some of our folks are so isolated, and so there is this sort of drive from the patient to sort of reach out for that connection. So that has definitely helped. And then I think another area where we didn't necessarily have as much anxiety but has gone well is also with medication-assisted treatment and doing buprenorphine care and even inductions over the phone. And I think that team is really skilled and has been a team that's working a lot in outreach settings and has already used phone, not quite in the same way, but a lot with provider-nurse consulting back and forth and putting patient on the phone with the provider, even if they're in person with the nurse. So I think that helped us adapt for MAT, and it's been, I think, a huge blessing for everyone that we've been able to do those inductions over the phone in a pretty streamlined fashion.
Yeah, that's fantastic. Jan, what would you like to share about ways to build connection remotely?
So this has been a difficult journey. I'll start with some of my challenges that in my team, I hear my staff or my coworkers talking about is what people are mentioning about personal connection and also distraction. Not only the clients are distracted because of their environment, but also as a provider, I have often caught myself, during the session, not having that one-on-one presence because of our setting, we are not face-to-face. So one of the challenges is distraction and also being present during the session with clients. So what I have started doing is I'm starting my session with checking in, asking clients how they're feeling, asking them to rate their mood from 0 to 10, 10 being the highest. And then I start with very simple deep breathing exercise so that we are both present. And also I kind of talk about how easy it is to wander. Our mind starts wandering when we are not in the same office room, not have that facial one-on-one face contact or one-on-one presence. And that seems to be helping with me and my clients, and also a lot of validation and empathizing that how difficult this situation is, and reminding clients that they are not the only one who's struggling. We are all in it together, and that seems to be helping too. But it is definitely a little bit easier with clients that are already established and new clients. For new clients to creating that space, the safe place that we cannot create now, and also establishing a relationship and trust over the phone, it's been very challenging.
I bet. Let's expand out on the challenges side of this. Jan, are there other challenges that you all have experienced that you'd like to share?
I think it's more, even though initially not having any experience with telehealth, I thought it's going to be easy, but as I'm doing more and more telehealth, I feel like it's very emotionally taxing. Like I do feel tired, and I'm sure our clients feeling the same way as we are feeling. And serving this homeless population is challenging because a lot of times our clients don't remember they have appointment, they're not in a safe place, they're maybe in a neighborhood or maybe just in their houses or they're living in a shelter. So, you know, having that sense of security and creating that safe place for clients, I struggle with that too. And it takes a lot of reminders and a lot of coaching, I think, and for clients to kind of understand and also take it important stuff, you know, having this session, not when they're riding bus, but having this session when they're by themselves, taking some time for themselves.
Thank you. Marty, can you share about the challenges you've seen with shifting to more telehealth?
Well, I would definitely agree about like privacy. Sometimes things that you don't, I guess, patients don't necessarily think about is the importance of being as much as possible in a comfortable private place because, you know, the kids are running around or whatever. Sometimes people sort of start the session and you kind of have to say, you know, let's see. Can you go outside? Can you do this or that? I would say also, and I don't know if we're going to get into this, but something that's probably a challenge is just the tech. You know, that sometimes, again, we're in a rural area, and sometimes people have good reception, and sometimes they have really lousy reception. So some of that can be trickier, is to try to help, you know, say, well, let's try it from the park. Let's try it from, can you go outside? Let's see if it's better there. That's kind of frustrating. I don't know. Yeah, privacy. Sometimes, obviously, you're missing out on the visuals. And I think it's true what somebody said about being tired. I was thinking about that as you were saying that I think because I'm not seeing the person, I am super hyper-focused on the nuances in their voice. And that can be kind of tiring. I haven't heard that back from patients. Okay, I don't know. Mr. Marty.
Well, just the other disciplines. Dental is really a challenge. Our dentists are able to do very limited assessment by telephone and address, you know, immediate needs in terms of managing pain, prescribing antibiotics, prescribing pain meds until the patient can get in for a face-to-face visit. There's some dental education that could be happening that, but beyond that, we really can't do much for dental services by telehealth. And as far as medical services are concerned, we're actually, you know, a lot of our patients would benefit by having home monitoring devices for, you know, vitals and OSATs and so on. Also, patients who don't have good communication devices, we're actually going to be requesting funds through an FCC grant to purchase a lot of this home monitoring as well as computer equipment to make available to patients. But yeah, without these devices, the remote visits can only be so effective.
Thank you. Joanna, what challenges have y'all experienced?
Yeah, I feel bad. I feel like that list is turning to be longer than the successes, but I think it's really not. I think it's just a learning curve in some ways. So a few of our things, I think we struggled the most in permanent supportive housing where we typically have in-person integrated health care. So we generally have a nurse on site, some access to a medical provider, and then regular behavioral health care. And so we left, for PPE purposes and community need, we left our nurses in the buildings, and they are still working in the buildings, and they're pretty regular schedule. But we pulled behavioral health to do telehealth care. That was really hard for patients. I think we just got tons of feedback despite the work with nurses and case managers at the buildings. that folks just did not want to connect over the phone. I think partially there was this feeling like this is temporary. It's just for this 2 weeks, or now it's just for a month, and we're just going to wait till this person comes back. And I think it's slowly starting to settle in that this is going to be much longer than people realized. So that's helped a little bit, but I think in some ways it's just isolated people further, as there's sort of mixed messages about staying in their room and isolating from other people in the building. So that is a really big challenge for us. I think partially that went into the platform. Neighbor Care is using Doximity primarily, which is a platform where essentially patients are calling in. We're calling out from Doximity, our providers, to the patients, and we needed something where patients could call in so that they could use like housing building phones of our nurses, and potentially their own if they had them. And so we actually ended up using in our homeless programs, specifically in outreach, we are using Ring Central, which is free for the first 3 months, and is a phone number that gets set up that you can call in or out. And now we're starting to get close to our 3 months, so that becomes a new challenge, if the organization will adopt that or not going forward. So I think that's been tricky. We've also, I think in PSH with that population there, has struggled a lot with like paranoia and who's on the other side of the phone, and just in general like technology literacy. And so we actually have, we've actually put behavioral health providers back into the buildings, and are trying to do some in-person or like walking therapy in as safe and socially distant way as we can, and found just an enormous uptick in doing that. So I think that is where we found if you're already bringing care in someone's home where they're at, and they already don't have to go anywhere to access it, it's such a larger barrier to, I think, remove that and try to shift that to phone. And I'd be very curious if others had other experiences that were more successful. We are getting some phone uptick, though, for a few that are working at home. And I think the other challenge has been, like everyone said, access to phone and Wi-Fi. It was sad for me because our youth, I think our homeless youth and young adults are so adept at technology and sometimes have access, but lost all their Wi-Fi access initially from the places where they would go during the day. And now our libraries have added and opened their Wi-Fi outside, which has helped a little bit, but I think that population is already one that when we pulled outreach at first was just really struggling. So I think they need a lot of encouragement and reminders to come in for care. So the more we've put our outreach worker back out into the community, the more successful we've been. But I think that's still been a challenge for us, just access to phones and Wi-Fi.
Sure. Regina, what would you add about challenges you've seen in New York?
I think the biggest thing we had is, the lack of equity of broadband capability for us to be able to do this effectively. That had been a limiting factor. The irony of having a psychiatric visit go weird on pixelation was, not funny, but funny. You don't really want to see someone's face go into a terribly dysmorphic projection while you're talking to someone who could be seriously psychotic. The other thing is that, ironically, there was a social engagement component of sitting in a waiting room for many of the patients that we care for. And I think some of that was underestimated, and that this whole kind of isolation, semi-isolation, distancing has taken away the ability to have sort of a gathering place, and that the waiting room phenomenon was kind of a gathering place for individuals who may not have other contexts for social gathering. And I think that may be something that will need to be thought about and realized more as to how if you think about it, a waiting room in these days is an anachronistic concept. People really don't wait for anything. It's all urgent and important for everybody involved. But if you could, maybe convert the even limited spaces into some kind of resource sites, that it might be part of this transformation. But those are two elements, broadband and social convening spaces, that are challenges we hadn't really thought about.
Thank you. We had a question come in through the chat asking how everyone is paying for telehealth visits. Regina, would you like to talk about that side of things?
Sure. So New York State, that was another big challenge for expanding telehealth services previously, was that there was not reimbursement. During this period, there were revised New York State Medicaid guidelines that gave a fraction of the FQHC PPS rate for telephone, and really like about 1/10 of it, and maybe 60% for audiovisual visits. And the State Primary Care Association lobbied very effectively for a revision, saying that, you know, this is sort of going to be the death of the safety network of primary care and behavioral health sites for the most vulnerable population, and the result will be overwhelming utilization of emergency rooms at a time when the emergency rooms have no excess capacity, and have been effective that for this period of time there is equivalent reimbursement for telephone and telemedicine visits. Whether this will continue remains to be seen. We've done a lot of training with the providers and finance in terms of what documentation is needed to be able to appropriately submit the claims and the changes in coding for the site of the recipient and the site of the provider of care. And that's been a major component of making this transition, I don't know if we'd say successful, but workable. So, yeah, and I think a lot of it's going to remain to be seen how and what will happen going forward.
Yeah. Marty, how about in Maine? What are you all able to do?
Everything. We as when our governor declared the state of emergency, she was very clear about the fact that with FQHCs, our PPS rates would remain intact, even if did not have the status as a telehealth provider. For the period of the emergency, we're able to bill for telephone visits with just a simple modifier tacked onto our PPS CPT code. We're still holding all our Medicare claims. We keep getting mixed messages in terms of how to go forward with billing for Medicare visits, but we understand we'll be seeing at least the $92 level of support for each encounter. We don't know. And then finally, with commercial payers, the governor's order obligated them to reimburse for telehealth services as they would for in-face visits. So we really, to the extent that we are providing services, we're able to bill for them.
That's great. Jan, what about in Baltimore?
Yeah, we're also, Baltimore, we're able to submit our claims and we're getting paid for it. So the regulations are relaxed now, and we can bill only using telephone visits. So it's been going so far so good. I know that claims are submitted and now we got payment. So I will leave it this way. Yeah, it's covered. Till now, I'm not sure how long this will be. I think it was previously it was till end of April. They have extended it. So we'll see.
Thank you. And Joanna, how about in Seattle?
I don't feel like I have much to add. Basically, it's been the same. We've been able to bill for services, which has been great, and had a work group that created a lot of documentation for our back office and front office on how to do that, and so that's been really helpful. And it was interesting because we went on Epic. We went live on Epic, a new medical record, on February 4th. And so, while the pros and cons, let me tell you, it's been very stressful to go. We went on to that in less than a year time of preparation, and then immediately had COVID things happening in Washington very early on. So it's a lot, but it's kind of funny because we had all of our EPIC groups up and running. So we sort of took everything we learned from planning this big transition to EPIC and have been able to sort of just carry on with the change management into this current reality.
Wow. And I have to say, just listening to all of you talk about these really incredible dramatic shifts that you've accomplished over such a short period of time, it's amazing the work and the focus that you all have devoted to serving the people that you serve. So thank you for that. We've got about 5 minutes left in our chat today. So for our final question, I'd love for us to look forward and think about, what do you think your organization's telehealth offerings might look like after this COVID-19 outbreak? Joanna, do you want to start us off with this?
Sure. I mean, I hate to be the first one to say this, but it's going to be about reimbursement, I think, and, you know, what we're financially able to sustain. I mean, I don't think we're going to return to any sort of old normal. I think we're going to have a new normal. And I think I'm hopeful that there are positive impacts of a new normal, both on our ability to access telehealth outside of very rural areas and reimburse for that, as well as, you know, other things in the homeless population and how we've seen, at least in Seattle, people be able to spread into more shelters and decongregate a bit. So, yeah, hopeful, but I think it will really depend on CMS and what others decide around reimbursement.
Sure. Marty and Marty, what do you all think about when you ponder the future?
I want what I hope, and again, all of this depends on reimbursement and all of that good stuff, but is that we can be a little more flexible to try to meet clients' needs as far as giving people choice, which I think would be great, you know, but because we have had, like everybody else, certainly in behavioral health anyway, you know, a no-show rate that's not, you know, pretty high, and so for some people it might suit them better. So we'd like to be able to give people a choice. That's all.
Yeah, I would second that, and also, as I mentioned earlier, we're very interested in having our patients, particularly those with chronic conditions that require a fair amount of management, have devices at home that will allow for a broader range of work that medical providers can do with their patients at home or remotely.
Jan, what would you like to see in the future?
I echo with what everybody just said, that, you know, I would definitely would love to see having this as an option. We have seen that, you know, telehealth works and it's doable. Hope we can do the reimbursement and continue, not all, but have the options, some options for telehealth in the near future.
And Regina, what would you add about looking to the future?
I mean, I think that there's an element of it that could be amazingly increased access if there's a way to overcome the lack of equity in smartphone ownership,
Right.
or if we somehow linked to health center enrollment with a smartphone capability that then confers access to almost a concierge kind of practice. And then internally, we have to look at, you know, what really does need to have a face-to-face encounter. Even in the most exclusive concierge practices, there's a requirement at least once a year for face-to-face comprehensive physical, and then no narcotics done remotely, et cetera, et cetera. And the other is looking at outcomes, because, you know, evaluation and phlebotomy and monitoring blood pressure are all elements of care that that require more than a virtual interaction of the third kind, I guess. So, I mean, I think it could confer increased access, and it's going to need to be coupled with a whole revisiting of how we deliver the kind of care that we're comfortable with, and probably a different type of skill set for providers, because even just televisits, what do you look at? Do you look at the camera? Do you look at the screen? Do you look at the ceiling? And how is that all part of what makes the visit more or less credible from the perspective of the patient in terms of building a relationship? So I do see it as a huge opportunity with a lot that has to be thought through on multiple levels, and it's going to open up different levels of inequity in terms of access, whether it's broadband or smartphone use.
Well, thank you. We are at the top of the hour now, so thank you all so much for being panelists and sharing your experiences today. Thank you so much to everyone who attended and everyone who commented and offered questions and helped us move our discussion to hopefully cover most of the things that you brought up. Good luck to all of you in the work that you're doing. We are happy to be here to support you. And on the screen right now, you see that our next coffee chat on Tuesday is on continuity of care for residents of permanent supportive housing. Please join us for that if you like. If you're not already signed up for the Council's e-communications, you can access that list at nhchc.org/join us. And in just a moment, a brief evaluation will pop up on your screen. So I hope you will take a moment to share any thoughts that will help us plan future chats. So take care, everyone, and thanks for being here today.